We have got everything. We have our image, but is it of diagnostic quality? So, welcome to RadSound FRCR Physics. You remember we started with the source, we got say patient, signal, detector, image formation optimization. So now we're gonna optimize a page so that in this lecture, I'm going to talk about making the image to be of diagnostic quality. Image that have content noise, lot of noise, motion blurring, scatter fog, poor contrast will all make image to be bad quality to make proper diagnosis. So we have to understand 6 or 7 most important factors that will help us to say and make proper diagnosis. We have contrast, noise, resolution, unsharpness, a bit of geometry, distortion, and artifacts. So I usually call them OMDA, like CRN OMDA. You call them CRN OMDA so they can be able to remember them well. Where C stand for contrast, and R stand for resolution and noise. We have U on sharpness, M magnification, that geometry. Then D stand for distortion, A stand for artifacts. So all the 7 must be well optimized for image to be of better quality, to make proper diagnosis and make proper management of the patient based on the image quality. So image quality is very important. Its visibility depends on the 5 most important interlinked domains. Among them, we have contrast, resolution, noise, we have a few artifact and geometry. These are 5 really important qualities. So we say contrast to noise ratio. Contrast to noise ratio is a big quality which is diagnostic ability to replace sufficient contrast to noise ratio is the signal difference between object and background divided by the total image noise. So if the contrast is beta, then the image would be of diagnostic visibility. If the otherwise, then the image will be fog, will be veil, and we cannot make proper diagnosis from that image. So if we get something which has a large signal differences, so we'll make image beta or visible. A low contrast legend may disappear even if it's physically large because it has low contrast and there is high noise. Small high contrast object may vanish from the blur because if we have more blurry, more noise, that small object may not be seen throughout. One really important concept to understand for the FRCR, contrast resolution and spatial resolution are no interchangeable terms, so they are a bit far different. We're going to explain each one of them into details so I can differentiate them because of the importance, because of the exam, because of the daily work. So for the contrast, we have subject contrast, we have film or display contrast, and also we have an image contrast. So regarding the subject contrast, it depends or it arises from the attenuation differences between objects within part of the object. Each part of the object we have or body part we have different attenuation capacity. You cannot compare lungs to the liver, to the soft tissue, to the muscle, to the bone, iodine. So at differences in the attenuation capacity will give object subject contrast. That subject contrast will help us to make diagnosis. For instance, if we say lungs, you say it's black because most of the photon will be transmitted through lungs because it has low attenuating capacity compared to the iodine, which will attenuate almost 80 to 95% of the beam passing through it. These differences in the attenuation capacity of the different parts of the body will give the subject contrast. So we have, for instance, we have tissue A, which is bone, low Earth transmission. So most of the photon coming from the X-ray passing through bone will be attenuated within the bone. Okay, only small amount between like 5 to 10% or less will only be transmitted and reach to the level of the detector. Remember, we have secondary photon. That secondary means scattered photon, which is taking misposition and misrepresenting part of the body. And whereas the tissue B is soft tissue, mostly almost 65% of it will pass. So high transmission is more soft tissue than bone than iodine. Okay, so that's differences in the attenuation capacity of the body part gives the subject contrast. And subject contrast depends on the following. As we mentioned before, we have atomic number. Okay, we have density, That's electron density, the effective atomic number, and electron density, also thickness of the material. All of these three will help to increase in each one of them. Each one of these of the three will lead to increased subject contrast divided by the energy. Energy is in inverse relation to the subject contrast. So the higher the energy, the lower the subject contrast. So for if you increase kbp, like high kbp will lead to less tissue contrast and vice versa. Sometimes also we have to look into contrast agent. If you are using a contrast agent, okay, like iodine, this was increase photoelectric effect. Increasing photoelectric effect means increasing atomic and density also. So at the same time, this will help in increasing tissue contrast. So then if the structure lacking, you're capturing the layers, blurring, noise, background, and others. So the less the noise, the more will be better the contrast, and vice versa. As I'm saying, if we have low kbp, that low kbp will lead to high subject contrast, because subject contrast is in inverse relation to the energy. Okay, so like that will be more absorption, okay, of the protein, and then in the vice versa, increasing the kbp, as you can say, will lead to decreased subject contrast because the photon will become more penetration. So increasing kbp will increase quality of the beam. The intensity of beam will become very high, but at the same time, the main trade-off here is that subject contrast will go down. So increasing kbp, we have to know that if you increase the kbp, the subject contrast is going to drop down, okay? Despite we are increasing the intensity of the photon passing through the tissue. In addition to increasing kbp will increase patient dose, okay? So increasing kbp will lead to decrease subject contrast, increase patient dose at some time. So main trap for the FRCR exam, you remember, high kbp will decrease subject contrast, but displayed contrast is not related to the high kbp. Why? Because displayed contrast mostly depend on the windowing, okay, window width and window level. That's the next part of the contrast. So after getting our subject contrast, now what's next? We have image contrast. So we have subject contrast, then the image contrast. So image contrast is shaped by scatter, detector, response, and processing. So image contrast also will help to make image better. But remember, you cannot manage, you cannot change what you haven't captured. If from the first place, the protocol of capturing, you didn't make proper positioning, proper removal of scatter, still the image will not be good despite anything that you will do. Okay, so you have to start everything as right as possible. So all the image, the quality of the image will depend on the three of them. We have subject contrast from the patient, image control, mostly detector, and then you have your own displayed contrast. So what's displayed contrast? Displayed contrast depends on the window width. So what's window width? Window width means the range of the density that has been displayed on the screen or on the monitor or anything. Okay, so the range of that density, so you can start from the low to high, that's from 0 to negative, positive. So the higher the window width, the less the contrast. So meaning that window width, okay, that's W, is will show you the range. Okay, for instance, we have 0 here, and then if we have here, this side is positive and this side is negative, here is negative. So meaning negative will be darker, okay, dark will be dark, and the other part will be bright. And this is the center. This part, which is the center part, the central location or display of the window width is called window level. So this is the window level. Remember, this is really important for exam. So this is the window level. So window level is the central part, central location of within the window width, and the window is a range of the displayed density. So now, if the density is more toward the negative, it will be darker. So window level is showing brightness. Window width is showing contrast. Window width is displaying different types of contrast. So the narrower the window width, the better the contrast. The narrower the window width, the better the contrast, and vice versa. Let's in this presentation, as you can say, we have, okay, you are increasing. So windowing changes appearance. Okay, you cannot destroy the information through noise, blurring, because you cannot mention or change anything that you haven't captured from the first place. Okay. Let us talk about scatter, the impact of scatter and degradation of the image. Okay, so scatter, as we mentioned before, there are procedures or protocols that we are using in order to minimize the level of scatter, of scattered photon from reaching the detector. As we mentioned before, we have said we can start from this part, the pre-patient. Okay, this is pre-patient. Okay, before reaching the patient, this part is pre-patient, and this is a patient level, and this is from here to here is post-patient. So what are we doing in the post-patient, pre-patient? As we mentioned last time, the most important, you can do collimation. Okay, collimation. You collimate the gate. Okay, you collimate the main window of capturing. So if you are taking, or you are going to take lower upper limb instead of taking the whole body part, you can just collimate, reduce the size of the window so they can capture the part, because the thickness is directly proportional to the scatter. If the thicker part of the body is capturing larger parts, there will be more scatter. So we collimate it. After collimation, we add something which is filtration. Add filtration. Filtration, depending, can be size filtration, can be anything. So filtration is very important. It will filter out the low photon energy. Photon low energy will be filtered out. Okay, so in such will decrease the amount of scatter, formation of scatter as the photon reaches the patient. So now the photon reaches the patient. What are we doing to minimize the scatter? What we do is that we do sometimes compression, especially in breast. We do compression and proper position of the patient, proper position, and also now post patient we still we have scatter. What shall we do now? We do something. We add grade. So grade is something that we place in. So we can have focus grade. Okay, with the spaces. So we place the grade between. So grade will allow the primary beam to pass while attenuating the secondary or scattered beam from passing. Okay, by late muscle. So now after grade, time we place air gap by increasing. This is a patient. Okay, it is object. Okay, this is a detector. Okay, so object detector image, from object to image distance. We can increase this distance so that scatter may not reach to the level of the detector. So we increase the object image distance, just what we call air gap, instead of placing the slate. So because placing grid will lead to increase high dose to the patient, so we just use sometimes we use air gap. Still, sometimes that air gap may lead to increased dose, because if the image quality is no better, it's not good. Still, the dose might be higher compared to not using either scatter, either the air gap, or the grid. And the last method we use is geometric play. So in geometry, you can use a small focal spot instead of larger, because larger might lead to a blurring. So you can use smaller one for better sharp of the image and better details. And so, and to minimize magnification, also to decrease blur. All these methods, we are using them in order to minimize amount of scatter from reaching to the detector, so that we can have a better image quality. This is the main illustration of scatter. You can see incredibly the column. So what are the factors affecting scatter? The main factors affecting scatter, as we mentioned, the size of the body. Okay, if the body is a large patient, larger body part, so that will increase scatter. So if we're using high KBP, will increase scatter. Sometimes while decreasing the main subject contrast. So poor collimation, because the size, the power you'll be capturing, you are capturing small part of the body. Still, you didn't collimate well. So poor collimation will lead to increased scatter, size of the body, thickness of the body, and the high KBP. These are among the factors increasing scatter. So what are the methods also I mentioned? Collimation, air gap. These are among the things that we are employing or using to minimize scatter from reaching the patient. So now noise. So quantum noise arises mostly from the random nature of the photon detection. It's not detection of the photon is random. So that if we have low photon count reaching the detector, that will lead to increase very high noise and less contrast and less diagnostic of the image. This ratio is approximately equals root of noise. So signal to double, if we say like we double we double the MA, that's the dose of the current. So it equals like root of that. So if we increase the MA by 2, by doubling it, the signal to noise ratio will increase by 1.4, not by 2. This is common in exam. They will say doubling MA improves signal to noise ratio by approximately 2, which does not mean they will say will double the signal to noise ratio. So doubling MA will not double the signal to noise ratio. It will make it increase by 1.4. But quadrupling MA will double signal to noise ratio or triple it, meaning it will be almost around 2.8. So it does not also triple it, sorry. So if you want triple, you must increase it by factor 5. So in that, you can have it up to 4 point something. So doubling MA does not double signal to noise ratio. So to help this, because this is trade-off, you are increasing dose and so that for better signal. Instead of that, we can use a detector which has high DQA. With a high DQA preserves input signal to noise ratio more efficiently, achieving the arcade image quality with the fewer incident photons. And also remember, a smooth image does not mean the image is automatically optimized. So optimization is very important. Let's say now we talk about resolution. So what is resolution? As I mentioned, so contrast resolution. So what is contrast resolution? Because we have spatial resolution. So contrast resolution is not equals to the spatial resolution. So what is contrast resolution? Contrast resolution is the ability to distinguish small differences in signal intensity. You can see now, we can see this, we can differentiate them, we can see this, we can differentiate each one of them. But remember, there's something here, you cannot see it. So meaning the low contrast object disappear when noise is high. So we have high noise here and the contrast disappear totally. You cannot see the object because it's low contrast and high noise. So the problems we are going to have in our optimization is that contrast resolution describes discrimination signal differences. So if object is having low contrast and it happens that it's high noise, we cannot see that object, and we can miss some nodules in the lung because it's in high noise, because of high noise, and the nodules may appear low contrast. So anything that might be low contrast in a setting of high noise might be missed in an image. So what are the factors mostly affecting the contrast resolution? As we mentioned, high contrast noise ratio from the start, okay? Adequate photon number, because you have more photon, there will be less noise because they are in a big proportion, okay? Because signal contrast noise ratio, signal noise ratio is proportional to the root of noise. So if you have more photon, there will be less noise and a better contrast. Lower scatter, high detector DQE, okay? And vice versa, like increasing patient, larger patient, have more scatter, underexposed, maybe the exposure index is less than deviate to the negative side, maybe -3, so it'll be darker area. You cannot see anything, you may not see anything, maybe overlapping due to improper positioning of the patient. What about spatial resolution? So as I mentioned, contrast resolution is not equal to the spatial resolution. So what is spatial resolution? So spatial resolution is the ability to display two closely related or two closely separated objects as distinct. So to see this information, this one and this, and say this is another this one, like 1, 2. So this is differentiation ability to show two nearly objects and separate them separately. So this is what we call spatial in the space, or the way they are presented in the space. So this is what we call spatial resolution. While the contrast resolution is the ability to distinguish them based on the signal intensity. This one is high, this one is low. So just low, high signal, this lower signal, so just contrast resolution. But ability to see them separately, but to see this is lung, or this is trachea, and this is lung. So just you can see them separately. So this is what we call spatial resolution. So signal differences is called contrast resolution. Separation of nearby objects as they are presented in the space, spatial resolution. So differentiate G's because it's really very common in exam to be stated as traps that may make a candidate fail in the exam. So just an example of spatial resolution. You can see this as a result. So okay, you can see them separately. You can see this marginal, but this one you cannot see them. So this is spatial resolution. Can you say these are two objects? No, we can't. What about this? We cannot match marginal a bit. But this one has better spatial resolution. This one has better spatial resolution, and spatial line, okay, per millimeters. Okay, that's line per millimeter. All right, per mm. This spatial resolution. So mostly we are using modulation, modulation transfer function, MTF, for the spatial resolution. So the beta, if we have like the modulation transfer will show us how well contrast is preserved at each spatial frequency. So high frequency will give us better fine details, or will show display better or fine detail of an object. So we have to talk about something called Nyquist limit, because we have to detect we have to talk about Nyquist principle and criteria. You know, the Nyquist limit says is that it is the highest spatial frequency a sensor or detector can accurately capture without error. So in saying that, we understand spatial resolution measures how much detail a system can preserve. Meaning, if you capture an image, just an image, so this image went to the detector, okay? So how how this detector, the ability of this detector to present this image into detail, to preserve what's meant to be captured, that is called spatial resolution in another language, okay? Another part of explanation. So the highest frequency, the detector that this detector can detect accurately and capture without error is called Nyquist limit. The call, okay, this is really important to understand. The highest frequency that this detector can detect without error. This is called Nyquist limit. So if limit passes or limit has been something go beyond the limit, that will be problem. Less than the limit, that will be problem. And that problem that will happen is called aliasing. Aliasing. If we have the highest frequency is not preserved, then that will be aliasing. If also the high frequency could be captured, then again aliasing. So this is what we call aliasing artifact. And at the same time, that maximum signal frequency that the digital system can accurately capture or reproduce from the image. We have our image, okay? So the maximum frequency that the detector can produce, okay, is called, that frequency is called Nyquist frequency, okay? Nyquist frequency. And that Nyquist frequency is equals sampling rate, okay, sampling rate over 2 divided by 2. Since Nyquist frequency equals sampling rate over 2, it means Nyquist frequency equals half sampling rate. So in a situation whereby we can have a bit blurring, we can have aliasing and others. So mostly what we are using is to prevent such thing, we place anti-aliasing such as low pass filter, a kind of filter like this, okay? It will allow only, okay, it will allow only frequency that is above or within the limit, the Nyquist limit to pass to reach the detector. Anything that is not up to the limit will not reach the detector, and that in such will prevent aliasing from occurring. That's why sometimes we use a smaller pixel size to prevent occurring of the aliasing. So pixel size limit sampling, but does not determine the total system resolution, because we have spatial resolution, we have contrast resolution, all of them together will give the image quality. In addition to low, contrast, we have got noise, geometry, artifact, and others. So not only the pixel size will give the system total system resolution, it is just part of it. So in this geometric part, we may not take much time. You can say increasing the focal spot, making it bigger, will lead to blurring and penumbra. Okay, as you can see from the illustration. So moving the object away or toward the X-ray will lead to magnification. If you are moving the source, that will be magnification, something that will call blurring. So when it comes to lead to magnification, what about the size, magnification, distortion? You can say places, misplacement of the object. You can say, okay, moving the object away or misplacing the object will lead to distortion. Now let's talk about artifact. There are different type of artifact. The artifact could be from the patient or an external, such as motion, clothing, something outside, okay, foreign body, on the body, ECG lead, and other. So as you can see, for instance, in the X-ray test, muscle patient from ICU, you can see ECG leads. So can be green artifacts from Maria, so like wavy lines on the X-ray or image, detector abnormalities such as ghosting, dust contamination, the ghost image, especially in CR. Sometimes processing, content mottle, the noise, saturation, wrong algorithm, and others. So acceptable digital brightness does not exclude under or overexposure. And artifact is not synonymous to noise. Acceptable brightness, as mentioned. So we can have something, the artifacts. So artifact can be easier to remove, but mostly noise. If we capture something already with the noise, it may not be of diagnostic value at all. So let's say, what is the importance of optimizing our image? To optimize image, it's gonna help us to have better image quality. You have your current image start setting, you have to know KBA, fill grid, and others. Contrast, noise, resolution, the very important geometry, artifact, and others. So this is the end of this video. See you in the next video.